Okay, so we've talked about a lot of the different treatment decisions on the initial therapy of patients with follicular lymphoma, but let's now move to second-line therapy. So John, we talked about how sometimes there's a lot of variability about how to apply the GELF criteria in the initial timing for first-line therapy. What about second-line therapy? Are you theoretically using the same criteria? Do you have a lower threshold to start treatment?
So I think there are some similarities but some differences. First, I think that patients, when they relapse, tend to present with less disease than when they were diagnosed. They know they have lymphoma, so if they feel a lymph node or they have a symptom, they're in your office quicker than they were at the beginning. So I think, and it's interesting when you look at studies that look at this. I mean, the bulk of disease at the time of second line presentation, at least, I think is typically lower than it is for the average patient at first line. So typically the patient's coming in with a palpable lymph node or some symptom. I think that, what you're looking for in that scenario, A, is transformation, because roughly half of at least the early progressors and a substantial fraction of the later progressors are going to have transformation. And so some of these people come in very sick with transformed disease, and that's often an important scenario. For the non-transformed patients, because they often present earlier, I think that while the criteria are the same, many of those can watch and wait. And I think, in my mind, there's even less rush to do a therapy in a relapse patient, because you kind of expect that this is going to be a relapsed lymphoma that you're going to be dealing with on and off for many years. Because it's relapsed, it's declared itself. And so, yes, I'm using the same criteria more or less, but we tend to be, I think, a little more relaxed as far as rushing to do something. Nonetheless, you still have to kind of counsel the patient, because they're disappointed. They think they're the one who is going to be cured, and they're not. And it's kind of obviously, I don't want to say devastating, but concerning for them.
Right. So John, let's get beyond the heterogeneity between the different nations on when to start therapy. But let's agree that you've decided to start therapy. We've also touched upon your initial decisions are really important in then subsequent therapy. And maybe you're not always the person who made the initial decisions, but trying to find a sequence for patients. So talk us through a little bit about how you approach the second-line therapy for patients with follicular lymphoma, the non-transformed patient.
So yeah, I completely agree with John. So you're right. You're talking here about a patient who's now come to the point they've relapsed. So now either they've relapsed and you feel that they need treatment, or they've relapsed and progressed to the point you need treatment. We've got one additional piece of information over at a relapse that we didn't have before. That's the duration of response that they had to the previous therapy, and of course what therapy they had before. So the whole sequence of what your first-line therapy has is going to potentially have a major impact, and the duration of response is also going to have a major impact. There's lots of indications where if somebody's had a very long response to a therapy and they tolerated it well, you could go back to the same therapy again. You do have to counsel the patients then, of course, to expect that here you're going to relapse, and the time to relapse is usually shorter with second-line therapy. I think we'll come back and talk later about some of the more experimental agents that we're hoping will be able to overcome that barrier. But in general terms, the data is very clear that the duration of second response is usually going to be less than the first. You're absolutely right, though, that if we've had a patient from frontline therapy, we've given and delivered the frontline therapy, but we're all working at major cancer centers where a lot of our patients are referred in. And you could actually argue we see more relapsed patients than frontline, because a lot of the frontline patients get treated in the community, whereas at relapse, they're often sent in, at least for opinions. So we're seeing a lot of these patients, and they may not have had the frontline therapy that you would have delivered, but that then it can impact your second line therapy, because if you've already used bendamustine, they've had a short response, you're not going to use bendamustine containing regimen again. If somebody has not used bendamustine before, you've got that available as an option. So you've got to take together all the information you have on the patient, and already alluded to, they may have more comorbidities now because they're older. But we also have the piece of information of how well they tolerated the therapy before, to give you clues as to how what kind of therapy and how aggressive you want to be. So you've got a little more than just the comorbidity stuff that we've talked about before. You've got how well they accepted the therapy.
And so how about also the comorbidities? I mean, we talked about the age, right? So you told us that in your world, no one uses single agent rituximab on the frontline setting. But what about in the relapse setting? Now that you're 80-year-old person that you've managed so well for 10 years and now needs something, what do you use single agent? Are you back with chemoimmunotherapy? Are you given,
You're raising very good issues. Again, you're talking here about, if you're talking about, I work in a large cancer center in the middle of London. It's quite difficult for 80-year-olds to make if you almost by definition, if you can make it into central London through rush hour traffic, you don't have high comorbidities. So you've got to remember that the patients are going to be treated in different in settings and in different environments. And you're right. So in that setting, there are patients in whom I would consider rituximab monotherapy to be an appropriate treatment, based upon your expectation that they would not tolerate anything else. And I think that's appropriate, because here we're always talking in follicular lymphoma potentially about palliating, because we're not offering the treatment with curative intent. But as John's already alluded to, once somebody's relapsed, you're really talking about palliation. You're talking about getting the disease away with the lowest morbidity you can for as long as you can. So yeah, I think there is still a place for single agent rituximab, or there used to be a place for single agent rituximab. Whether we now add it with some of the other agents that we now have available to add to it. And as we're already hearing, what you're also hoping to do is if we can just keep patients going for that little bit longer, there are new things coming that would be available for them in the future.
All right, I'm going to continue to pick on you because you've published. When John Leonard was in high school reading your papers, the use of transplant in follicular lymphoma, is that dead?
Well, it's not dead, but it's certainly true that it's done. If you look at the registry data, there's many fewer autologous transplants being done. I think it still has a place. Where its place is and in which patient becomes is clearly much less done. The data would suggest that if you're going to do it, identifying a patient who's got higher risk disease, doing it earlier in their treatment course makes sense. But of course, it comes with very significant morbidity. But I've got patients still alive that I transplanted 30 years ago, before you were born.
I was born. It was nowhere near high school.
So yeah, I mean, I think it still has a role, but you've really got to think carefully and select the right patient for it.
I totally agree. I continue to use consolidation with autologous transplantation in second line for young patients, for selected patients, so with very good result.
Very, very good.